Thanks very much, Lee. First of all, I'd like to welcome everyone here and congratulate the NBA on rolling out these symposia, which I think are going to be fundamental to helping with implementation. I'd also like to applaud Michael's talk and through him the Commission on not only having these 10 standards, which I think all of us in the clinical workforce have welcomed because they are clinically relevant and they're not just a tick box. So thank you, Michael. So the meat and veg of what we're here for today is in setting to achieve these accreditation criteria. And I think that's thank you, that's probably not as daunting a task for this audience as maybe some of the other accreditation standards are going to be. So I came to this place from the other side of the door probably 30 odd years ago, and I dare to say that a lot has changed, but you're probably wondering what's gone on behind the door, and I can't give a talk at these meetings without bringing along my surgical colleagues. Once they decided to dress up for surgery, they looked better, but their attitudes didn't necessarily change. When we spill that much blood on the theatre floor now, we suck it up. This is a liver transplant theatre where with intraoperative cell salvage and reinfusion of washed, warmed blood, we can maybe manage a patient's massive transfusion of 50 or 60 litres safely and get a good result. So a lot has changed. What I want to spend a little time talking about, though, is coming back to the fundamentals. What are we doing with a unit of blood? You speak to a donor, they say, I've given this blood because I want to save a life. I want to make a difference to the community. Very altruistic. We've got voluntary, non-remunerated blood donors in Australia, and that's precious. We're a doctor. We say, we're giving it to improve tissue oxygenation. I think when I saw the video that Lee showed, I'm sure you all agreed, I thought if that goes for another 5 minutes, I can sit down and go back to the Austin because a lot of what I'm going to say was really well expressed in that video, but how good is the picture of the microcirculation? What about where the blood goes? Well, this is from the Blood Service website. It's easy to find out. It is interesting that in fact, the vast majority of blood is going to patients with serious blood disorders and other cancers and medical anemias, and many of those transfusions, providing they're given correctly, will actually be life-saving, as they will in massive transfusion for trauma and particularly obstetric hemorrhage. But the low-hanging fruit is in those middle categories, and that's really why we're here today, to try and stop or reduce those 1 to 2 unit transfusions for people having elective surgery. I want to spend a little bit of time today talking about the risk conversation, because I think as we try and partner with consumers with the new accreditation guidelines, this is the challenge. What do we say when we go to get informed consent? Or the patient says to the orthopaedic surgeon, what's the benefit of a transfusion? And the 1970s or 80s or even 90s or 2000s response was, you might need some blood for your surgery because although I'm good, I spill a bit. It helps carry oxygen around your body. Well, we've seen that that ain't necessarily so. And it also, and this is the one where we've really got to work hard, it'll help you get over your operation. And how many of us as people involved in perioperative care have heard that bullshit? It's the only time I'll swear, I promise. I'm not at work now. The patient then says, will the blood transfusion be dangerous? And then the clinician says, no, don't worry. This is not the 1980s. Australian blood supply, and I can say that with my hand on my heart, is really safe. It really is. You won't get AIDS, and we're always really good at all our checks and processes, so we won't bugger it up and give you the wrong blood, and we'll only really give it if you need it. Well, in 2001, these very noble guidelines, which were designed to try and inform clinicians about when to give red cells, platelets, fresh frozen plasma and cryo. And interestingly, and we're involved in this with Blood Matters, when you started to audit against these guidelines, there was a huge lack of awareness and there was certainly a lot of inappropriate transfusion. And that led us to what is now occurring worldwide. And again, proudly, I think we can say in Australia, we are leading the way in this paradigm shift. So in the mid-2000s, the language of patient blood management arrived. I think we need to remind ourselves what it is. And I love this definition. We put this definition into the guidelines because we thought it captured everything. And it's an aspirational thing, aims to improve patient outcomes, clinical outcomes. And you'll hear some more today about how we are working on achieving those compliance with those pillars. And quite clearly, it's a pivotal element of perioperative care. I want to just spend a few minutes going through the process. The NBA convened groups to get together from a wide range of specialties and clinicians with expertise in transfusion medicine. And was importantly, this has been a big investment by the NBA, but I think it's going to yield a lot. There was then a systematic reviewer, so they're professional literature searchers, and we also had the privilege of working with a couple of independent systematic reviewers who are endorsed by the NHMRC. What did we do? We wanted to focus on the clinical setting, not the blood product. And as you all know now, we set about setting up these 6 modules, and through 2014 the obstetric module will come online, and hopefully not long after that the paediatric one. I don't want to bore you with science, but it's really important to understand what we went through. This started in 2008. It's like painting the Sydney Harbour Bridge, it'll probably never stop. But it was a very scientific approach, and we knew that there wasn't a lot of scientific evidence in transfusion medicine, sadly. But there was a body of evidence matrix which looked at all these issues that allow us to score the level of evidence. And we applied very strict NHMRC grades for coming off the fence with a recommendation. Importantly, again, for the scientific-minded in the audience, and there are lots of you, this was using PICO criteria. So you select a population that you've studied, what's the intervention, what's the comparison, and what's the outcome. At the end of all that, and I can't tell you how many hundreds of thousands of published articles were reviewed over the period leading up to mid-2009. If we thought there was sufficient evidence, we made a recommendation, but if the grade of evidence wasn't really high, we wanted to try and get the wording right to reflect the level of evidence. And as you'll see from the various modules, there's lots of areas which were clinically very important, but a little bereft of solid scientific evidence. So we worked very hard. We actually had a medical writer working with us to help select the right language that went into the guidelines. So what have we got? I reckon this is a pretty good little snack pack, and there's 2 more to come. And this 6-pack, I can tell you, going to other parts of the world, this is setting the standard internationally. Nobody's done this. Other people have started to put the toe in the water, and what we're saying is share these guidelines, build on them, don't reinvent the wheel. And Australia is leading the world. So this is a quick run through though to demonstrate to you that there still is not a lot of evidence and we need to do more. The perioperative module, which I want to spend a little bit of time talking about, is the strongest one in terms of levels of evidence, and the others less so, but equally important in terms of what we are trying to achieve. I want to spend a little time talking about what I see as the critical elements in trying to implement this. 5 key areas. The first one was one of the major recommendations was that in places where a programmatic approach to patient blood management in the perioperative period has been put in place, then that is sufficient to drive a recommendation. How do we do it? Well, today is a fantastic example of that. You need to have enthusiasm at the hospital level, so people are going around saying, what's the blood transfusion committee doing? Are we talking about patient blood management? Are we measuring transfusion outcomes? How do we collect the data? And really importantly, at a governmental level, every state now, it's taken a while to put some stakes in the ground, but every state now has these agencies which are front and centre in terms of implementation of patient blood management. Congratulations to the NBA for their foresight and their investment, and importantly now, the Commission has really given some traction. You'll hear later today one of the really key areas to picking off this low-hanging fruit, and that is to manage and identify and manage anaemia before elective surgery. This is data from Hans Gombots, who was in the video from Austria, and it demonstrates just the prevalence of anaemia in preoperative patients. And you can see, once you get into the age group that are increasingly presenting for surgery, between 10 and 25% of patients have anaemia that you can improve. So Peter McCall's going to be talking about this, a program that we've run at the Assoc, and there are lots of other places around the country that are starting to embed anaemia management into perioperative care, and this is the tool that can be adapted and used, and this is in the guidelines. I don't want to spend any time, because there's a lot of detail, talking about how we manage the difficult patients who might be on aspirin's pretty easy, because that's safe for most types of surgery, but clopidogrel and other more recent anticoagulant medications are quite challenging, and we address some of those issues in the guidelines. What about minimising the intraoperative blood loss? This is really, really important. And there's a range of strategies, again, all in these guidelines, that we can look at. One of the few recommendations that's got grade A evidence is keeping the patients warm. Intraoperative cell salvage, there's a guideline into how to do that. Tranexamic acid now has become routine in joint arthroplasty and in cardiac surgery. And these technologies of cell salvage and point-of-care testing for major surgery like liver transplantation and cardiac surgery do help us manage the patient's coagulation status, and again, use component therapy wisely, not empirically. To me, though, the most important factor in minimising perioperative blood loss is the Neanderthal with the spear, okay? We have to, and we are getting some runs on the board, we have to modify the way surgeons operate so that everything about their surgical technique is designed to minimise blood loss. And there are lots of tricks as to how that can be done. And they need to be routine, not just when it's a special case. Modern techniques for minimising tissue damage, topical agents, including those listed there, and in cardiac surgery there are novel techniques for reducing the amount of hemodilution associated with cardiopulmonary bypass. So when I talk to surgeons, I say, you've operated on a few JW patients, why don't you do the same for everyone else? How can you not do the same for everyone else? Finally, in terms of the PBM program, I think this is the biggest challenge, to provide transfusion decision support, usually for the junior docs, but also their bosses in the wards post-operatively. And, dare I say it, also in the medical wards, because there's still a lot of dogmatic, inappropriate transfusion on medical wards because the boss said, top them up. We know there was poor compliance 10 or 12 years ago. We know there is still poor empirical use, particularly of component therapy, and we need to educate our clinicians about allowing the patient's anaemia to recover spontaneously. So when I think about tolerance of anaemia, I think about it not only in the patients, but getting the clinicians to tolerate the patient's anaemia. Again, there's emerging evidence from the literature, quite recently that if you're a JW and you're having cardiac surgery, you're going to do equally as well and sometimes maybe even better than the patients who are not treated as a JW. So this is pretty basic stuff, and this is what the NBA is driving, and we as clinicians want to not just jump on board but absolutely embrace. We know transfusion's not without risk. It's an expensive resource, and although with PBN kicking in now, red cell use in Australia is drifting down, it'll plateau in the next 3 to 5 years, if less, and then as we all get older, we're going to need more blood. So it's a real challenge. It's now become imperative that the principles of patient blood management are just routine, not only in the surgical setting, but in non-surgical patients as well. And the evidence is emerging that this not only leads to these 4 improved outcomes, but allows us to look after patients better. I want to come back now and spend a little bit of time just looking at the clinical side of this and what's driving the clinical decision making. We need to always, before we order a unit of blood, ask these 4 questions. They're fundamental. A lot is talked about risk. The risk of viral transmission of a nasty disease is now so low, it's negligible. There's still a risk of a hemolytic reaction which could kill the patient, more likely from an administrative error, and so how important is that? The blood service on its site has this histogram which goes through a summary of those transfusion risks on the left, and importantly, I think for patient information and also for decision support for the doctors who are getting informed consent from the patients, a little bit of comparison about some other health risks. However, we can't drop the ball here. You've only got to remember, and I remember the 1980s when patients got hepatitis C in droves around the world. Some patients got AIDS. We did a liver transplant on a patient about 5 years ago who was a haemophiliac, and in the 1980s he got a double whammy. He got HIV and he got hep C. He went on to need a liver transplant. We don't need to go there again, and we have to be vigilant about transmission of serious disease. We also have to be vigilant about our checks and processes, and the SHOT group in the UK have led the world in the area of haemovigilance, and even in this recent decade there's still significant risk to the patients if we get it wrong. Trali used to be called something else, probably shock lung in Vietnam, and probably a whole lot of other things, acute respiratory distress syndrome due to anything in the decades since, and a lot of what's occurring in people on ventilators after massive trauma or other conditions is probably Trali. You've seen, and this slide's almost redundant now, having seen that fantastic video, but why does stored blood potentially do you harm? Well, it affects your immune system, it's got a pro-inflammatory effect, and it's not as good as your own blood when it comes to the microcirculation. A little bit of time just to scoot over what is a huge amount of the evidence, clinical evidence, that was behind these guidelines. We know that anemia is bad for you. We know that if you treat anemia with transfusion, the superimposition of the transfusion is even worse for you. There's a lot of work going on in cardiac surgery, and I really want to touch on it, but again, these are not fantastic studies because they're observational, they're not randomised controlled trials, but there was a lot of emerging evidence that transfusion in cardiac surgery increases your risk of not only death, but other serious morbidity outcomes. And these statistics don't lie. And what's interesting here is look at the overall transfusion rate. Nearly 50% of patients getting blood. On the other side of the Atlantic, Gavin Murphy from Bristol did the same thing in the UK and also found hazard ratios for death and other important morbid outcomes that were up to 7-fold for patients who'd had a transfusion. I'm sorry, there are probably more women than men in the audience. It's known, we've all known for a long time that women's outcomes, particularly mortality after cardiac surgery, is worse. Is it potentially related to the fact that they've got a lower red cell mass, they're going to hematolute more on bypass, they're more likely to get a transfusion? This study wasn't perfect, but again, it invites some serious questions. What about the critically ill? Enormous amount of work in the last 15 years or so in relation to the evidence from transfusion risk in the critically ill. This started with Paul Hebert's study called the TRIC study, probably landmark study in this field, demonstrating, again, this was a prospective trial comparing liberal versus restrictive transfusion in ICU and demonstrating reduced hospital mortality. There followed over the next few years a large number of studies with generous amounts of patients in them, again showing an association, not causation, you can't do that from these sort of trials, with transfusion and worse mortality. And again, the literature is expansive in this area. Some of it observational study and some of it RCTs. What about trauma? This is an area surely where a blood transfusion saves lives. Of course it does. But in the trauma literature, again, the superimposition of red cell transfusion, particularly relating to the more you get, the worse it's going to be for you, beyond that which is going to save your life, again, important papers that inform our clinical approach. So, how do we distill all this? Well, this is a really important paper because I think it sort of highlighted what we've all known for some time. There's enormous variability in the prescription practices, if you like, for this precious product that someone's donated. If there was that much variation in pharmaceutical prescription, God knows we'd be in trouble. Bruce Spiess, who's Ari Shander's mate, another almost a zealot for patient blood management, but a very well-regarded authority, wrote this in a paper 5 or 6 years ago, saying that there had never been any evidence supporting the benefit from transfusion. That's pretty sobering. So, the future continues to be bright. We had to stop our systematic review mid-2009 for the perioperative module. The other work is ongoing, and as Leah's already said, there's some fantastic research in transfusion medicine right here in this country, right here in this state, that is leading the world. And I won't go through all of those, but you can track them. So, let's come back to the coalface and this standard. We need to engage with the patient, and a discussion about informed consent now is a little bit more than you won't get AIDS. We need to document while we're doing it, we need to transfuse against a standard policy, and we need to assess the efficacy of that single unit transfusion and whether or not there's been any harm from the patient. And my strong belief is we also need to measure the clinical outcome from the patient. And that's more challenging, but we can do it. I applaud, this is I think on Lee's website, haemovigilance. It's not just a catchphrase, this is a fantastically important term. There's a national haemovigilance group under the NBA that started, again proudly, with the Blood Matters program and the STIR reporting incidents in transfusion, and now as a national program. But this is important not just for transfusion episode adverse events, but surveillance for the whole transfusion chain, really from donor, not just to vein, but from donor to vein to outcome. How are we going to do this? Well, again, we put some advice, if you like, not gratuitous, I think well thought out through that data management is the key to this, and we need to have methods of linking data, and again the NBA has led the way there, and the Blood Service has also got lots of, pardon me, tools for helping with data collection. National coordination goes without saying, but how good is today? You know, we've got all the players in the room and there's a lot of investment and enthusiasm coming nationally. So this is really controversial. Some people who talk about patient blood management say blood doesn't save lives, it kills people. None of us believe that. Of course it's a precious gift and it saves lives every day. But that's why it's precious, that's why we don't want to waste it, and that's why we want to use it appropriately. So when we say we're going to give someone a transfusion, we need to not only think of the patient and what we're doing for them, but take yourself to the donor centre and think about our responsibility to the donor. Thank you very much.
That is a lot of information in a very short space of time. I'm sure it's generated many questions. Can I invite questions from the floor? Well, I've got one. If you were, there's been about 4 years, I think, Larry, since the PBM guidelines, since the clinical review group gathered. 5 years. There's been a lot of evidence come out since then. Where, if you had to redo, or when we redo the guidelines, and we're currently in planning for the next revision, what do you think the major changes would be in terms of current recommendations and practice points?
Look, I think the answer to that is I don't know, but I think the challenge is not to redo them, but to refresh them and revisit them. And they are a good product as they stand now, but we've talked about this, and I have conversations with people in other parts of the world about this issue. And I think what we need to do is share these with everybody and then inject new data. The transfuse study is really important. Jamie Cooper from the Alfred's the lead investigator. It's an ANZICS-driven study, and it's looking the age of blood. Okay, there's a lot of talk about the age of blood. Intuitively, the older blood is probably worse for you, and a lot of people are voting with their feet and saying, I only want to give fresh blood. But that's not fair. It's not equitable. We need the evidence to say, boom, boom, boom. So when that comes, we need to, find a way, probably through the websites, to continue to update.
Questions? No questions? You don't want to do the... No. If you ask the question, I'll announce it for the...
Basically, I'm on a team lead for a couple of standards, and one of the struggles we're having is junior medical workforce and education of that cohort of staff coming in, not just for the senior medical workforce as well, but how do you, where do the universities sit in providing education for the juniors so that they come out knowing this stuff? So that's just a thought, because HIA is a perfect example of that with antimicrobial stewardship, things like that. But I think, like if the universities, I know we...
Yeah, no, it's a really good question, and we discussed this a lot at the clinical reference group when we were trying to formulate some of the language of the guidelines and trying to anticipate how best to implement them. So it has to be an ongoing process. I think you don't have to wait for the next generation. There's generational change occurring all the time. Most of the medical students now have got fancy devices in terms of uploading all the stuff they need. Transfusion medicine had trouble getting on the undergraduate curriculum. It's still got a way to go, but talking about patient blood management as part of patient care in undergraduate curriculum, in nursing education, and importantly also through the specialist colleges. And again, the colleges here have made a big investment because all of the colleges are on board about these guidelines. So, I think the issue of turnover of staff in hospitals is one thing, but maybe I'm eternally optimistic, but I think over time everyone will know about patient blood management. I hope.
I think one of the big problems, I think that the education of the young doctors is going quite well. I'm more concerned about getting those
Yeah,
So,
the old dogs, yeah.
Can you summarise the question, Larry?
Yeah, no, sorry. The question is really not so much the junior medical staff and nursing staff, but the dogmatic, the man with the spear. So that's the challenge, because I think getting this, what we're talking about today, out to senior medical staff, visiting medical officers in various places, whether they be surgeons or physicians or whatever, is remains a challenge. I guess what I'd be suggesting is that it's got to come from below, and we've got to empower the junior docs and others to say, look, I know you said top the patient up from 85 to whatever so they can go home after their knee replacement. The junior docs need to say, oh, I've just been reading about that on the website, and can we have a conversation about it? That's the way I think. Don't you think medicine's changing, Barb? I reckon the old dog can't get away with it as much. And they'll die soon anyway. We just give them blood. You've almost got to, well, that's a really important point, single unit guidelines here now. That needs to be almost stopped by someone, medical director, coming in saying, you're not allowed to do that. Well, there's no evidence that it worked. That's the whole problem. As I've tried to say in the talk, there's never been any evidence that topping up the haemoglobin with a blood transfusion is good for you. There's dogma, because when I was a medical student and a young doc, that's what I was told to do. But that's, I'm not prepared to say how long ago it was, but it's a long while ago.
What has changed is a number of hospitals have successfully implemented restricted use. And it's not just at the moment, in summary, it's why use two when one will do. There was a clinician in the Sydney Symposium that said they've moved to why use one when none will do. So it's, you start there and you move, and there are now documented success stories. New Zealand has had a very successful restricted use policy. It's localised, depends where your power centres are in your hospital. I mean, I'm not telling you anything that you don't know, but it's a matter of, there are now a lot of demonstrated successes.
The other thing is, that's why data is so important. And your local hospital blood bank should be helping with data collection. And I know that a lot of you in the audience today who are really good at that, but we need to be auditing the appropriateness of transfusion and then monitoring the behaviour. It's a bit like Michael said in the guidelines, plan, study, do or check, and revisit the practice.
I'm going to have to hold the questions. As I said, we've got a crammed session. Are you here till lunch, Larry?
Yeah, till lunchtime. Yeah.
So please, I'm sure Larry would be more than happy to talk to you. As you can tell from his passion, he is one of the main champions in the sector for patient blood management, and it really is clinicians telling other clinicians how to practice. A fantastic resource, and on behalf of everyone here, Larry, thank you for taking the time to speak to us.